All right, everyone, thank you for joining us tonight. This is our DMC Medical Group educational series, Heart to Heart series, coming to you now on every third Thursday of the month at 7 p.m. Today, just for some housekeeping items, these webinars will be recorded for all the presenters and will be hosted also on the YouTube channel for your leisure to see at your convenient time. For our participants online, we're going to have these questions open for the speaker and the panel throughout the webinar. So please make sure you post your question in the chat box. And again, thank you for joining us tonight. With me is the co-host is Dr. Kenton Zer. He's our director of cardiovascular marketplace at Michigan for Detroit Medical Center. And we have been hosting this series for almost 7 months now. This is session number 7. With no further ado, I would like to introduce our guest speaker today is Dr. Yevgeniy Rits. He is the DMC vascular surgeon. He is a program director of vascular surgery, as well as the director of dialysis access and DMC. The title of webinar today is Advances in Dialysis Access. Before we open the webinar and share with Dr. Rits, we'll start with the intro video coming to you from DMC.
So good evening, everybody, and it's my pleasure to showcase our Dialysis Access Center, and thank you again for this opportunity. I really believe that Dialysis Access Center, Harvard University Hospital, is kind of a hidden gem. We started the program about 10 years ago. It has a tremendous success. It grew tremendously. So right now we servicing about 12 to 1,500 patients a year, and see about 800 patients throughout the year. 600 of them require surgery, and all of this in the heart of Detroit. We are the only hospital-based dialysis access center in Michigan, and we're probably one of few dialysis access centers, hospitals based in the country. Being associated with the big medical center, we are not only providing dialysis access to patients, but also we have several outreach programs. We do go to different dialysis centers and educate nurses and cannulators. We also have several training and educational programs for the different providers and for our patients. Several vascular surgeons and interventionalists come to us to get trained. So I just want to share with you what we have and what advances we can offer to your patients in terms of dialysis access. Why it's all important. One of the reasons is dialysis access. Kidney disease is a big problem in the United States. About 37 million patients or if 37 million people have chronic kidney disease, of 90% of them not even aware of it. There are about 500,000 of patients on dialysis in the country. Of them, 22,000 only in Michigan. And if you think about it, if we service about 1,500 patients, it means that we servicing about 0.5% of entire kidney population, kidney dialysis patients in Michigan. The cost of Medicare is tremendous for the dialysis, and it has over 36 spendings are 36 billion a year, and for a patient annually, Medicare spends about $100,000. The cost is increasing every year, and here I share a slide with you that from 2004 to 2016, the cost of dialysis care almost increased by 2.5 times. Originally, our country, we recognize that has been a problem that we need to deliver dialysis care more efficiently. And the goal was to provide care through the fistula and create fistula first. However, very quickly we realized that although fistula is great, we need to really target individual patients, and each patient has individual needs. So dialysis access care grew tremendously, and we have tons of different innovations. So now, since the care expanded and it gets really, really costly, there is, in 2019, presidential executive order has been issued trying to focus dialysis access through and dialysis care through kidney transplant, peritoneal dialysis, and home dialysis. So what's dialysis? Dialysis is a kidney replacement therapy when blood being drawn out of the human body into the machine that filters the blood. And we need some sort of, in order to do that, we need some sort of interface that would connect patient to the machine. And that's where dialysis access comes in. And us as vascular providers and vascular care providers, we implant or we provide that access. And one of the simplest way to get access would be to insert a catheter. And most of us and most of you currently seen this catheter, and you think that there is nothing new and exciting can be created with this dialysis catheter. However, one of the few innovations was for the catheter was to create a cuff that would prevent ascending infection, and by placing this cuff allowed provide long-term care for the dialysis. And believe it or not, this cuff was invented by one of the professors of cardiothoracic surgery at Wayne State University, Dr. Cantrell. It's about 30 years ago. He's the one who invented this ingenious little thing that was attached to the catheter. And so now we can use dialysis access through the catheter mostly indefinitely. So what are the complications of the catheter? Of course, although it can stay in the body forever, very common, it gets infected, and it also can accumulate thrombus. And because it's a foreign body in the vein, also creates some swelling and deformity in the extremity. So this catheter has been around, and you would think, again, there is nothing new cannot happen to this catheter. However, in the past year, there's been development a new type of catheter that separated the tips of the catheter in a little kind of Y configuration. By doing so, it limits amount of thrombus formation. It also doesn't allow this catheter being close or being next to the wall of the atrium. So when it sits in the body, it doesn't accumulate thrombus, and the patency of this catheter increased tremendously. And now by placing this special type of catheter, the 6-month patency increased from 60% to 91%. Which allows deliver much better care to the patients. And again, this catheter is available at our institution. So the catheter is good, but in reality, this is not the best way to deliver access care. And as a matter of fact, it's probably the worst way to deliver the access care. And if this is a busy slide, but it looks at the demographics of the patients that died within first 12 months after initiation of the dialysis. And they looked at over 4,800 patients. And if you look at the demographics, majority of the patients that died, they were on the catheter. So although catheter did not kill the patients, however, those patients that had dialysis through the catheter suffered a lot of complications such as thrombosis, infections, recurrent interventions. So what's the better way to deliver dialysis access? And clearly it's autogenous, or the dialysis access through the fistula. And you probably, those of us who takes care of dialysis patients, heard of semina fistula. And it's really what it is. It's a connection between artery and the vein. And if you can create a fistula in the arm, especially at the wrist, where you connect radial artery to the cephalic vein, it is the most durable and the most long-lasting fistula that ever exists. It's kind of what we call a Cadillac of all the fistulas. It has the longest duration of service. It also has the longest cannulation zone, so it lasts the longest, and it's easier to use. But it's the most difficult to create, and most difficult to mature, because cephalic vein that becomes arterialized has tons of side branches in the forearm, and they all have to be ligated, and they have to be shut down for the fistula to mature. But if it's created, it lasts the long time. We also can use vein of the upper arm, not necessarily a connection between cephalic vein and radial, cephalic vein and the radial artery, but also we can connect the vein to the brachial artery. And it could be, as simple connection between cephalic vein and brachial artery at the elbow, or it could be a basilic connection, when we use basilic vein that runs on the inner surface of the upper arm, and we just simply move it out onto the brachial artery. It's both of those fistulas are excellent conduits, and they use excellent conduits, and they're excellent ways to provide dialysis. And you would think that nothing new can be created. However, about 2 years ago, we were part of the trials, and we were one of the first in Michigan. We were one of the first in Michigan, and one of the first in Midwest, that created a fistula completely percutaneously. And now about 10% of our fistulas are done completely percutaneously. So what it is that we are capable to insert catheter in the artery and insert catheter in the vein, and navigate it to the area where the artery and the vein close to each other. We introduce special catheters that have magnets, and those magnets, so to speak, talk to each other. Then they co-opaque, and they meet, and they stick to each other. And by using a special electrode, we can burn a connection between the artery and the vein, which creates a fistula, and fistula is extremely durable. And again, we've done over 20 of them, and what's the best part about it is completely percutaneous, with no incisions, with no deformity of the skin, and about 6 weeks later can be totally used for providing dialysis access. Here, again, the picture that depicts percutaneous fistula that was done hours after, the cannulation sites were done after literally several hours after we performed the creation of the fistula. How good is those percutaneous fistulas? They're pretty durable, and having a cumulative patency over 70% at 390 days, and with the primary patency of 75%. What's also important that percutaneous fistulas not only durable and can and look good, they also have fewer interventions compared to open fistulas. So when we cannot create fistula, we go to old-fashioned grafts. What grafts do, they just simply connect artery to the vein, and we run them on the surface of the forearm or upper arm, and they can be, again, cannulated and used as a coupler between human body and the machine. We can, most common graft that we use is a connection between, again, brachial artery and axillary vein. And it allows easy creation. It allows a fairly long cannulation zone, easy to use. And we practically can connect any artery and any vein and with a graft, and we can create them in the upper arm. We can connect them in the leg. If legs and arms are being used before, we can tunnel them on the side of the body or across the chest. And you would think that, again, there is nothing new can be created for the grafts. However, with modern ingenuity and modern advancement in the technology, now we can use immediate cannulation grafts. So those are the grafts that have very low porosity, and we can insert them, and right there in the recovery, they can be cannulated, and patient can receive dialysis. We also were one of the first sites, and definitely first site in Michigan, where we entertained a special graft that venous end was looked like a T-shape. So what we would do, we make a small venotomy and insert this graft and expand it inside the vein without using any stitches. And it by pulling it back and snapping it in place, it secures itself. And for that, our dialysis access center was featured in Times Square. We were there for several days, and I received multiple phone calls because nobody believed that we can do that. Currently, our dialysis access center not only uses artificial plastic material to breach artery in the vein, but also in patients who have recurrent infections, we utilize biological materials such as cryoveins, such as cryopreserved veins, or bovine mesenteric vein, or human umbilical allografts. Those are excellent materials, and they're not mainstream, but definitely use different purposes. Some of them are less thrombogenic, which could be used, and they are used in the patients who frequently thrombose, or some of them are more resistant to the infections, and we use them in those patients who suffer frequent infections. Unfortunately, either grafts and fistulas, they are prone to failures, and they're prone to causing fibrosis and stenosis within the cannulation zone. So on average, our patients go through 2 interventions per year. And here, if you compare, definitely fistulas work better than the grafts, but if you compare 2 of them, they still carry very marginal patencies. So in order to maintain longevity of those fistulas and the grafts, we use several tools that are available to us. And in the past several years, we've been using drug coating balloons, very similar as in peripheral interventions. We use special balloons that are coated with immunomodulating drugs. This particular Lutonix balloon has paclitaxel, and we utilize this balloon in angioplasties in the veins, and they work extremely well. Here's a picture on the right that shows a diseased vein that has a significant proliferative reaction and significant stenosis. However, when it's angioplastic using this special balloon, it by causing slowing down the fibrosis, it really clears the vessel. So by using this type balloons, it allows us to space the interventions much further. And if you compare regular angioplasty to angioplasty with the Lutonix balloon, within a year, you have 114 more days of life with no interventions between two modalities. So if you kind of think of it, our dialysis patients spend 3 times a week, 3 hours a day on dialysis, and they don't have to come to the physician office for 4 months extra to receive cleaning of their fistulas or their grafts, or you can space their interventions by 114 days. That's a huge victory, because instead of spending extra time in the physician's office, or in the operating room, they try to enjoy their free time outside the dialysis as much as they can. If balloons don't work, we also, similar to the peripheral interventions, can utilize the stents. The difference, though, that our stents are they're different and they're special. Instead of using just metal scaffolding, we use covered stents. And some of those stents, like Catheter stent, was specially designed and the only approved stent for dialysis interventions. And here pictures show that we have a narrowing before the stent and narrowing after. And by using covered stents, several studies show that if you use them, you significantly increase longevity of the fistula. And if fistula or graft became thrombosed and you utilize covered stents, it basically reverses the natural history of the fistula as it never been thrombosed before. So again, manufacturers that focus on dialysis access, they kind of notice that the grafts work well and stents work well, and why not put them together? So this graft has the features of a stent, which is right here, that welded to the graft, and it's being deployed by just ripping this ripcord, and it expands. So this graft called a hybrid graft, because it has both features of a stent and a graft. And what we can do with it is we can completely percutaneously, without making any incisions, we can access the vein and deploy this graft inside the vein without making any suture connections. So why do we need that? Simply, we use it when technically we cannot sew to the vein. And it happens when the entire length of the vein has been utilized for grafts before, and we have no room. So by using this percutaneous access, we can go far beyond in the axilla, into the armpit, and connect it to the axillary or even subclavian vein and avoid suturing. And again, by doing so, we, instead of only putting 1 or 2 grafts in the arm, we can actually put multiple grafts. So it significantly expands the lifespan of the graft or fistula. And again, I believe in Metro Detroit, we are the only institution that uses those hybrid grafts. So what happens if you have a central vein stenosis? If you have a central vein stenosis, which happens very common in dialysis access, because when we hook up artery to the vein cannot handle arterial flow and develop significant scarring and eventually thrombosis. What we can do, we can put a different type of catheter. And again, we are the only center in Metro Detroit that does that. The dialysis catheter called hemodynamically reliable outflow, HERO catheter. And we have patients from all over Metro Detroit coming to us for this procedure. So what we can do is use this graft that has components of the dialysis catheter and components of dialysis graft, and we insert this rubberized hose or outflow component through the thrombosed segment of the artery, thrombosed segment of the vein all the way into the right atrium, and then sewn in an arterial component to the artery of the arm, connect them together so patients can get dialyzed through this. All of it tunneled underneath the skin. We took this technology even further, and we can also put it not only through the thrombosed clot, but we can also put it through occluded stent. And here you can see that the outflow component of the hero graft being threaded through the stent all the way into the right atrium, and then underneath the skin tunneled and then sewn in to the arm. Here is another example when we will put this hero graft into the occluded, into the occluded graft in the chest. And here this original graft that was placed and it was functional, then it became thrombosed, and you can see that there is a clot in it. And we placed the wire into the graft through the subclavian vein all the way into the heart. And here's a picture of the outflow component that going from the left through the graft into the subclavian vein into the heart. So it would allow us to connect functional fistula and create an outflow component of the hero catheter and going through the graft into the heart. So what it does, it prolongs the life of this fistula, and this hero graft was placed in about 5 years ago, and it's still functional. And this gentleman still using his fistula that right now is almost 10 years old. So now, one of the new devices that literally became available maybe 2 weeks ago at our institution is Surfacer. Surfacer is a brand new and ingenious device that has been widely used in Europe, and only a handful of centers use in the United States. What it does, it allows us to put a catheter in a completely occluded brachiocephalic veins and veins in the neck. So the way it works by placing a catheter through the groin and going through the heart and inferior and superior cava and kind of bury it into the clot of the occlusion. And then by using fluoroscopy guidance to go above the clavicle, and we put a target in the skin above the clavicle, and then thread the needle from the catheter through the skin, through that target. And that needle is a hollow. It has a ability to host the wire. So once we thread the needle goes through the skin, and we're capable of exteriorizing this needle. And then through the needle goes the wire, and by pulling the wire out, it gives us access to place a catheter. So here's the picture of the same thing when we put a catheter through the thrombus and then stick the needle out in the skin, and the needle is hollow. We thread the wire through the hollow needle, and then the wire becomes access for the dialysis catheter. So patients who had no chance of having a neck access catheter, now they're capable of doing so. And again, this is technology that's available at Harper Hospital. So in summary, dialysis access care has been around only for 60 years. And this is a picture of Scribner shunt that what it was a connection between the artery and the vein that was sewn in through the skin, and patients could get dialysis only for a couple of weeks. And then they would either continue to the transplant, or they either recover or they wouldn't make it. Now, with all this technology, a patient received dialysis for years and years and years. And I have some of the patients that have been dialyzed for over 30 years. And we are happy to provide this care for the patients. And we literally in the cutting edge, and we trying to evolve and provide the best care possible every day. That's all I have.
Fantastic.
Thank you.
Eugene, what a great overview. And I, as a surgeon, found this incredibly interesting because all of these technologies technologies are just phenomenal leaps forward in the ability to manage these patients, which early in my residency, and I was doing some vascular surgery, you know, this was like the scourge of our existence, was trying to keep fistulas open. I want to ask one question. You didn't say it because you're a modest man, but you had the privilege of working with Adrian Kanchowitz, I believe, when you were a medical student. And
it wasn't before even before.
And
I was
go ahead.
I was an undergrad student. Sure.
Well, Adrian Kanchowitz, for those who wouldn't know, performed the second heart transplant in the world. It was a pediatric transplant. He was in New York City at the time. Then Dr. Kanchowitz became the director of, I believe he was the chairman of surgery at Sinai Grace Hospital for many years and had a very active lab, of which Eugene worked in. He's not only known for the cuff on the catheter, but he's also known for something that bridges the gap between cardiac surgery and cardiology, and that's the intra-aortic balloon pump, which Tendon Cooley called one of the two major advances in providing therapy for heart failure patients, and that was Dr. Kanchowitz.
Yes, that's very true. He's a brilliant man, and I had a pleasure to work for probably a year and a half in his lab, and we were working on left ventricular auxiliary device that implantable. It's very similar to balloon pump, but it's implanted. And one of the reasons why he developed that cuff is that he needed the interface between the pump outside and or tubing outside and pump inside. So because he had a lot of problems with infections, and that cuff solved that problem, but it also gave a huge gift of ability to, have a catheter placed and stay there for years, for dialysis patients.
If you are a new onset person that's needing dialysis access, what is the longevity? There's just the average longevity of an access site. Can you expect them to last years if you take care of them, or
yes,
you can expect that?
Absolutely. Usually, if 3 to 5 years. So the way we usually quote is that, we start as far outside as possible. So radiocephalic fistula 3 to 5 years, then we move to the brachiocephalic fistula 3 to 5 years. Well, you burn all the veins, you can go to the grafts. And again, then you have a graft. So usually from each limb, you can get about 10 to 15 years. So
phenomenal.
And the main problem with dialysis access is that there are so many factors that involve. It's, it's not only conduit, but also how well the person that cannulates access has a knowledge of this access. So, cannulator is very important. So you cannot stick the same area over and over because the access becomes aneurysmal. So you need to rotate the needles, and you have to really take care of it. So because so many confounding factors involved. So right now, the greatest goal is to get patients involved in all of this, meaning that they become cannulators, they can do it at home. And that's what we're trying to do. We're trying to educate. And that's probably one thing that puts us or separates us for the rest of the dialysis access providers. So we're not only inserting those fistulas, inserting grafts, we're also educating people and explaining how it works and how to get the best run and the best longevity of this access. And my staff is phenomenal. The work that they do is really, a lot of hard work and a lot of dedication, and and that's what separates us from everybody else.
I heard that you mentioned that patients being active in their own care. We're starting to see patients that have their own hemodialysis machines at home. Is that a viable thing for most patients? And does it improve their, obviously it improves their quality of life, but does it improve the longevity of their fistulas if they're active in their care?
Oh, absolutely. You know, again, one of the key, one of the issues is that they understand that you need to rotate the needles, meaning that you avoid the same sites. It's kind of very intuitive, but if you're not the one who cannulates your own excess, you don't even think about it. However, when you do it yourself, you understand if you insert needle the same place, the excess get thinned and it rupture, or it's just not usable anymore. So when you educate a person and they're heavily involved in their own care, it definitely improves outcomes and longevity of the excess. And the machines are getting cheaper in price, and they're easier to use with the tons of alarms. If you get, because one of the greatest fear is that you become unplugged and you kind of bleed out. So now the machine has a lot of alarms that kind of tells you that something's going wrong. So they'll wake you up, or they start beeping, and you can actually do stuff and manipulate your excess and prevent any catastrophic events. And the machines get cheaper and cheaper and more sophisticated. Yeah.
Go ahead. So there's a question coming along, is kind of a little bit on the dialysis line, but it says, what are the percentage of patient on dialysis who has peripheral arterial disease, and do you routinely screen for PAD in these patients?
We don't routinely screen for that, and it's one of the right now lacking of manpower, but it's one of the thoughts that we would like to start a questionnaire and try to figure out if by screening patients we can improve also peripheral arterial disease outcomes. But 70% of our patients have some sort of element of the peripheral arterial disease, and we do take care of them, but we don't screen. Part of obviously history and physical, we do ask if they, if they're inquiring and asking for the care, if they, being disabled with their peripheral arterial disease, we do help them, but we don't really screen.
So another question coming from me as interventional cardiologist: do I compromise the patient chances of having AV fistula in the future if I go for radial access for coronary angiogram or intervention?
I don't believe so. I don't think you do. Every patient that we see, before we do fistula, we do the ultrasound. The problem becomes with radio. Remember how I kind of said that radius cephalic fistula is the best fistula? The problem is not the artery. The problem is the vein. Cephalic vein in the distal arm has a lot of side branches. So although it's a Cadillac and it's the best fistula, the maturation rate of those fistulas is very low. And my maturation rates are probably 10 to 15%, which means that I try to create them, but majority of them do not mature, not because of the arterial part, but because there are way too many branches and the vein doesn't become big enough for the cannulation. So we give it a chance. If it doesn't work, we move up to the elbow fistula.
Yeah.
Now, go ahead, Chadi.
What was there?
I'm very interested in the percutaneous device. I think it's genius. I remember one of my close personal friends was very involved in the development of this, and I remember seeing prototypes many years ago about this idea of using magnets and radiofrequency ablation between the two. Do you think that this is going to be going to increase in percentage as the skill set improves among vascular surgeons, or do you think there's a fixed number of patients that this can be used on? And the reason I'm saying is precisely for the reason that the low maturation rates in the lower forearm It seems like if you can get it done at the elbow percutaneously, you might get better results. Is that true or not?
Well, I think there is nothing better than open surgical fistula. And one reason is that you completely disconnect vein from the side branches. So one of the difficulty with percutaneous fistula is that you cannot ligate all the side branches. And it will catch on with other providers, like, maybe cardiology, interventional radiology, because they don't have open surgery skill set. But I think open fistula is still a very, very good option. So I'm more excited about percutaneous ways of providing fistula in low extremity revascularizations, when you possibly can do percutaneous bypasses without, without incisions, or even creating a fistulas between artery and the vein in somebody who cannot be revascularized. And that's probably a better, it's more exciting, because if, let's say, if you have somebody with peripheral arterial disease and not salvageable situation when you have no vein and no artery, and you create a small fistula between deep artery and the deep between the artery and the deep vein, and maybe save the leg, that's probably an exciting option. And I think it's something that people will look down the road, and I think they're looking at it right now.
You mean to improve your runoff?
Yeah, I mean, because if you, let's say you have no vein, no conduit, and by creating a small fistula between artery and the vein, maybe it will improve, flow, not improve flow, but oxygenation to the inner tissue, So that could be a possibility, because instead of making incisions, something like this could be done very easy and very quickly.
Is this a same-day procedure?
Yeah, it takes me just as long to do percutaneous fistula as open. So open, probably skin to skin, is about 30 minutes. This is probably even less. Wow. So it's radial artery, actually ulnar artery, ulnar vein access, and you run the wire up the vein and up the artery, and you put a catheter with magnets, and magnets meet. So the artery and the vein close enough, and you burn the connection, and you coil the outflow. So you coil outflow, the venous outflow. So you force all the flow into the cutaneous veins.
And what is the patency, and why the AV fistula thrombose? What is the number one reason?
One of the number one reason is that, well, this is a different fistula. This is the regular fistula thrombosis, because it's not really capable of handling arterial flow, and you have high rate of restenosis and a high rate of neointimal hyperplasia. This one, because you don't move the vein, you don't disconnect it, it's literally a connection between artery and the vein right there. It has higher patency because you don't move the vein when you do it surgically. The problem with percutaneous fistula is that you cannot get rid of all of the side branches close to the arterial anastomosis. So if you think of the fistula, if you think of it as a trunk of the tree, because if you take all the side branches, you want to create a really big trunk, and you can create really big trunk by cutting all the side branches, or all the branches that's how your trunk matures. So if you cannot get rid of all the side branches, you have a bush. So you have a lot of flow, and you don't have a main trunk. So one of the difficulties of percutaneous fistula is you cannot reroute all the flow into the main trunk, because you have tons of side branches. So selection is very important. Like, do a venogram, see how many side branches you have close there to your new anastomosis. By doing an ultrasound, see, like before doing a surgery, to see if your how your vein compares to the artery, and if you create it, if it's going to flow into the vein easily. So, I mean, it takes a lot of planning, but technically it's very easy to create. I don't know if it makes sense. I mean, for me.
Well, I wanted to ask you, you obviously have developed an expertise in complex fistulas. What percentage, or do you have a portion of your practice which is salvage operations for patients when all other centers have failed to be able to get permanent access?
Oh, absolutely. I mean, I don't have a percentage, but clearly there are certain things that nobody does. We probably the biggest users of this hero graft. It's when you have complete occlusion of everything in the neck, like all the central veins, and we can angioplasty the way into the atrium and place that catheter and hook it up to the graft in the arm. But we're looking at maybe 10 cases a year, and but it adds up because nobody else in Metro Detroit really using this. And we see a lot of people that come in for us specifically for this particular problem. When we have a graft in the leg, in the groin, they don't want to, or they have a catheter in the groin, and obviously it's they don't want to use it because they go to dialysis center, they have to expose themselves and sit there for 3 hours hooked up through the leg, or because again, the leg catheter or the leg graft it's not the cleanest area, so they have higher rate of infection, and so we have a lot of patients that come in only for this specific reason, to move this catheter or the graft from the leg to the neck. We also use a lot of hybrid grafts when grafts are mated to the stent where they have not enough room to place a graft. So we can actually, again, percutaneous. But again, we're talking about maybe 20 cases a year like this, but nobody uses it. When we do complicated stuff, our referral or our catchment area is very significant. Some of the newly dialysis centers there that we service, they're 20, 30 miles away from where we're at, and some of them could travel quite a distance. So I'm not going to brag, but lately our nephrology program is ranked 40 in the country, and they specifically mentioned that one of the reasonings why U.S. News and World Report named the top 40 in the country because of the excellent dialysis access care that our patients receive. So
excellent, Eugene. I wanted to ask the theoretical question. When you're a medical student, you learn about high output AV fistulas as a pathological problem. Right. Do you ever see this in your patients as a pathological problem where there's so much fistula flow that they have cardiac failure, or if they develop heart failure, a weakened heart, do they develop high output fistulas that affect their life?
We've seen in my 10 years practice maybe 2 or 3 fistulas like this. I think one of them was together with Dr. Terasaki when we looked at it a couple years ago, when we actually looked into it, and he felt that this patient has a high output failure and we had to ligate it, but they're far and few in between. It's very rare, and it's kind of surprising me too that really they don't develop high output fistulas. They don't develop heart failure.
Interesting.
Heart is an amazing machine that compensates really well, and we really don't see them.
All right, I think the last question I was about to ask was the heart failure, but we always have this high flow murmur. We teach medical students due to hyperthyroidism or because of anemia, pregnancy, but one of them is the high flow murmur. One of the high flow murmur is because of the AV fistula. We had one case, to Dr. Kenton, their point, it's a high output heart failure, not in our institution, different institution. So is it something technical in the fistula that causes some patient more susceptible to heart failure? Or is this because they have an underlying heart disease or risk factor that triggered them to go into heart failure?
I won't be able to answer this. I don't know. It's actually a great question. And I think we even talked about having a study about that. If by looking at patients and they're looking at the heart function before placement of the fistula, during and after, and see if anything changes. And maybe, patients on the dialysis have very high mortality rate. And so if you look at patients that have been on dialysis for 5 years, about 15% of them will die. And this high rate of death could be related to, having high output fistula and or fistulas that triggering something like this, and causing, death and going into heart failure and creating some sort of heart dysfunction. But it's a very interesting question. We never looked at it, but we probably should.
Okay, absolutely. Well, I would like to thank Dr. Rits for your time. I think we're coming to the end of the program for a phenomenal presentation talking about advances in dialysis access. We are one of the highest volume, I would say, nothing to brag about or be proud of, but our population is one of the highest dialysis center or population pandemic in Metro Detroit. As very sick population, very pathologic, and we really appreciate all what you are doing, Dr. Rits, to our patient and the community. Just would like to put one more thing, Dr. Rits, information here. He is located at the DMC Heart Hospital, and he does surgeries at the Harper Hospital operation room. With that, I would like to remind everyone as well that all these program are hosted on a YouTube channel. They will be edited, shortened, as well as available for all the audience at any time. So far, we have at least 9 or 10 programs has been already published, and there is more going forward. If you have any suggestion about topic you would like to hear about from our experts, please don't hesitate to reach out to me as well. The last thing I would like to thank Elise Bennett from DMC Medical Group marketing team, and KP also from digital marketing, for helping us putting all this program together, editing the videos, and eventually publish them to make them readily available for you and the patient. With that, thank you everyone for your time, and have a good night.
Thank you so
Thanks,
much.
everybody.
Thank you.
I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.